Hello everybody. Over the next half an hour or so we will learn what we've learned from prostate cancer screening programs that have incorporated MRI. Here are my disclosures. So there's four things we'll discuss. One is to learn that most of the data that we have so far in the MRI literature comes from the early cancer detection scenario, that is to say in secondary care, where disease prevalence is higher. And I'm going to try to show you that the harm reduction benefits that we see in early detection programs, in fact, do apply to the lower disease prevalence population screening programs also. I'm going to try to illustrate to you that the benefits in screening are very much dependent on age and whether PSA pre-screening occurs or not. And I'm going to point out the major limitations, the limitations being a low predictive value and an imperfect reader variability, particularly in younger men, and this requires addressing. So let's just start off by distinguishing early detection in individuals and populations, and I just wanted to highlight this briefly. Remember that early detection is to diagnose patients before symptoms for individual benefits to reduce the development of advanced cancers developing and eventually deaths from prostate cancer. Prostate cancer screening is quite different. Here, the aim is to reduce prostate cancer mortality for the whole population, and in one it is individuals. In the second one, it's an organized program targeted at men at a specific age. So really quite different. Now, in the detection settings, we know that there are four major benefits. One is it reduces the number of patients undergoing a biopsy, and it reduces the diagnosis of indolent cancers. The other two benefits are more accurate targeted biopsies and non-inferiority or slight superiority in the detection of clinically significant disease. Now, keep these in mind as we talk about benefits that we see in primary screening programs also. Particularly, I'd like you to remember the reduction of the number of men undergoing a biopsy and reducing the diagnosis of indolent cancers. These are the ones that you need to keep in the forefront of your mind. Now, on the right-hand side, you'll see a couple of studies in the early detection setting in secondary care, where you can see the disease prevalence is very much higher, 30% and 50%. And on the left-hand side, you'll see typical studies that have been published in the screening setting, with or without a PSA up front. And what I'd like you to do is just take a big picture look and look at the number of biopsy procedures. So if you look on the right-hand side, you see the total number of biopsy procedures when the prevalence is higher, up to 50%. Here you can see that most men will get a biopsy, regardless of whether they have an MRI or not. You can see 100% of men would get a systematic biopsy. If you did an MRI, 83% of men. So in other words, most men. But as you go to the left and as the prevalence lowers, you can see the number of men undergoing a biopsy reduces quite dramatically from 80 to 100%, and you can see it goes down to 20 and 10%. So you can see this gradual benefit of biopsy avoidance coming in as prevalence starts to drop. And of course, there are a number of ways you could do prostate cancer screening. The traditional way, of course, is just to do a PSA test and then a systematic biopsy, for which there is level 1 evidence. And we've discussed that in other videos. But you could take the MRI approach. So everybody just gets an MRI, fast MRI. And if you're positive, you get a target biopsy. And here are 4 studies that have looked at this. If you look across the top, the highlighted area, look at the disease prevalence in this setting. So in the prostagram study, you see on the left-hand side, it's 4%, 10%, 2%, and 3%. So the prevalences are really an order of magnitude lower than you would expect for secondary care, which is exactly what you'd think. Okay. The other interesting thing you'll notice is how many men avoided biopsy after a negative MRI. And you can see here in the prostagram study, 90%, then reimagine 80%, 88%, 90%. So a lot of men will avoid a biopsy after an MRI. The other thing I'd like you to notice is the positive predictive value. So if an MRI set comes out as positive, depending on the criteria, what proportion of those patients will have a grade group 2 and above? And it's really quite low. You'll see here, for example, it's 26%, here it's 20%, here it's 44%, but look here, it's 52%. That's very reasonable, but look at the prevalence. The prevalence is much higher. You see 4%, 2%, 3%, but here it's 10%. So as the prevalence in the cohort increases, we expect the positive predictive value to increase, and this is exactly what we see here. So big picture stuff, let's just look at the some other key learnings. One is over half of the cancers diagnosed in the prostagram study were in patients with a PSA less than 3. Okay, and that's identical to what the reimagined study found. More than half the men with a grade group 2 and above had a PSA of less than 3. So there is a real danger of using 3 and above as the cutoff, because you may miss half of the grade group 2 cancers that may be there. That's an important lesson. And if you look at the reimagined study, again, you'll see that the prevalence is much higher than in the prostagram study. And if you look to the right at the MVP study, which is another important lesson, I think, is that if you see something on an MRI, men are much more likely to accept a biopsy. And this is also an important learning from these studies. So let's just look at the prostagram study in a little more detail. So the schema is shown here. You can see about 2,000 men were invited, about 400 accepted, which you see over here on the left-hand side. Imaging was performed both at 3T and 1.5T. A few notable things are look at the median age. The median age is 57, so quite young. And you'll notice here that 10% of men had a positive PSA test. Okay, so 1 in 10. And in fact, that 10% number is something you should keep in your head, because that'll come up again and again. The interesting thing is, if you looked at these men with an MRI, and you used a biopsy, if you used a positive MRI as being 3, 4, and 5, you'll notice a lot more men have a positive MRI if you use a PIRADS 3, 4, and 5. But if you use just PIRADS 4 and 5, you'll see it's about the same number as a PSA test. And this is an important lesson. So when you have younger men, 57 in this particular instance, and you use the cutoff of 3, that's not really a good idea, because you will overcall a lot of men as being positive, and that's an important lesson. The other interesting thing is you'll see that a lot of men underwent a biopsy, and this is because of this, because you call 3, 4, and 5. And of course it helps us to biopsy more men in a study situation, because we want to know what the background prevalence is. And if you look at the number of unproductive biopsies, again in these 3, 4s, and 5s, a lot more. But if you look at the total number of significant cancers that were diagnosed, you'll see that although 3, 4, and 5 did detect more cancers, so in 3, 4, and 5 would have detected 14 of these 17 men who were eventually diagnosed with prostate cancer, you'll see the strategy that uses 4 and 5 is actually very good as well. It detects 11 out of the 17 instead of the 14 out of 17. But of course the PSA test is the worst of the whole lot. You can see only diagnoses less than half of the men with grade group 2 cancers. So these are some important lessons regarding younger men. Perhaps don't use 3, 4, and 5. Too many biopsies, too many unproductive biopsies, but maybe a little bit more clinically significant cancers detected. Now, the modern pathway for population screening at the moment is a PSA as a triage, and then an MRI, and followed by a targeted biopsy if that turns out to be positive. And these are the studies that have looked at this, and I've just arranged this by order of age. And you'll see that in the Prostate study, these men were very young, 45 to 50 years of age. These were 50-year-olds. These are 50 to 60-year-olds, and this is 50 to 74-year-olds with a median of 66 years of age. Now, if you look at the prevalence of disease, you can see in the younger cohort, it's just 0.2. Here, look, 50-year-olds, 0.57, less than 1%. Gothenburg 2 study, 1.2%, but look what happens here. As the age increases, so the prevalence goes up. And that's an important thing that you need to remember. And then if you look at the number of men with a positive PSA test, you see the positive PSA test, if you took a cutoff of 3, 1.5%, 3%, 7%, 12%. So remember the prostagram study was about 12%. You can see here it is, the prostagram study was 10%. This comes out as 12%. Okay, so what we're saying is that the older a man, the greater is the likelihood of them having a positive PSA if you took a PSA of 3 and above as your cutoff. Okay. The other thing you'll notice is what percent of men avoid a biopsy after a negative MRI. And you'll see that in younger men, very few men avoid a biopsy because we're calling 3, 4, and 5. Right? And that's a problem. Okay. And if you look here, as you get older, so the number of men avoiding a biopsy goes up. You'll see 60%, 67%, 64%. And the positive predictive value also goes up. So you'll see here, lowest positive predictive value, only 36%. Here, again, younger men, 30%. Gothenburg 2 goes up to 42%, and here it's 57%. So what would we expect to be the positive predictive value in a man who is typically about 66 years of age in secondary care, so in the early detection settings? And this is, I think, nicely summarized in this slide. So this was a study with over 1,000 men, 1,300 prostate examinations, lots of radiologists looking at this, these scans, lots of urologists biopsy. And if you look, as you might imagine, the positive predictive value for PIRADS 3 is about 20%, PIRADS 4 goes up to 50%, PIRADS 5, it goes up to 70%. So this is exactly what we expect from the literature. But if you took a PIRADS 3, 4, and 5 to be positive, then you'll see that PPV is 47%. And if you look at PIRADS 4 and 5, you can see that PPV is in fact 56%. So let's just talk about these studies in a little more detail. So remember, the Prostate study was in younger men with lower disease prevalence, 1.5%, and lots more indeterminate scans. So lower disease prevalence, lots of PIRADS 3 cases, and the interesting observation was that when reviewing these scans, it very much depended on the reader experience. So central readers were much better at saying this is normal compared to peripheral readers, and that's an important additional lesson. If we look at the OPT study, it confirms this issue of regional differences. So radiologists in one area, radiologists in another area will tend to call different cases in these younger patients, and that means that we need to be thinking about how we standardize the reading of these scans, particularly for these younger men. The Gothenburg 2 study was quite interesting, and we'll come back to it a bit later on, but it showed that performing targeted biopsies alone, without the systematic biopsies, would miss a few cancers. In fact, all of them are 3+4s, and what do we do about these patients is something we need to think about. But what I'd like us to do is to focus on the Stockholm 3 study, because I think that that is a higher disease prevalence, as we said, about 4%, with about 60% avoiding a biopsy. But look here, the PPV is about what we would expect for secondary care. So let's just look at these data in a bit more detail. So this is the Stockholm 3 study, the MRI study, and you can see then the proportion of patients with a positive PSA test was going to be about 10%, right? And here it is, 12%. The median age is older, you see what I mean? So not the 50s and the early 60s, but about 65 years of age. And you can see that 1,532 men had a PSA test of more than 3. These men were randomized either to a systematic biopsy or an MRI, and if an MRI was positive, again 3, 4, and 5, then they underwent a systematic and targeted biopsy. And what were the main results? You can see that on the right hand side. So the total number of biopsy procedures was lower with the MRI arm, and this is what we'd expect from secondary care. You'll see the difference here. It's exactly what we expect. Okay. The number of benign biopsies, non-productive biopsies, is lower, yes, in the MRI arm. This is what we expect. The diagnosis of grade group 1 cancers is lower with the MRI strategy, which is what we expect. And if you look at the diagnosis of clinically significant cancer, it's actually slightly higher in the MRI strategy, but it's not much of a difference. Statistically different, but not much of a difference, 18 and 21% respectively. So we can think about a number of challenges regarding the optimization and the integration of MRI into a screening program. And I've just laid these out separately for you. But one of these would be deciding what sort of man is best suited for an MRI. Do we just go by age? Do we go by PSA cutoff? Do we take high-risk men? Do we take all men? These are things that, as radiologists, we need to be aware of. So look at men at high risk. Who are men at high risk? Now, these men include men with genetic predisposition syndromes such as BRCA mutations, men from a West African diaspora, either in the USA, Europe, Brazil, etc., or men with a strong family history. These are all men at higher risk that we should be thinking about doing MRI. And here's an example. So this man has a known BRCA mutation in the family, and you can see a focal lesion anteriorly behind the behind the anterior 5 muscular stroma, and this turned out to be a 3+4 on a transperineal biopsy. This study looked at men with BRCA mutations, and the median age was 54. Now remember, when we looked at the 50-year-olds in the screening study, the ProBase study, you'll remember the prevalence of clinically significant cancer was 2.26. Look here. Look at the prevalence. It's 4%. And so you can see that these men are at higher risk of developing clinically significant disease. Now, in the end, you'll see that 7 men were diagnosed with grade group 2 cancers in this particular population, and a similar number of men with grade group 1 cancers. Now, look at this. If you did a PSA test versus PIRADS 3, 4, and 5, you'll see almost a similar number of men would have been called positive, which is what we saw before. But if you had taken PIRADS 4 and 5, then you can see it's much fewer men. Okay, so PIRADS 4 and 5, you would call less men positive. Unproductive biopsies will also be less. So PIRADS 3, 4, and 5 versus PIRADS 4 and 5. So you can see fewer unproductive biopsies, but the same detection of clinically significant cancers. So the PSA strategy is not great. The MRI strategy is better, whether you take PIRADS 3, 4, and 5 or 4 and 5. You detect the same number of clinically significant cancers, but a 4 and 5 has the advantage of calling fewer men positive and doing fewer unproductive biopsies. And this is something that should now be quite familiar to us as we think about this concept. And then the issue is, what PSA risk stratification should you use? That's an interesting question, because the secondary analysis of the prostagram study suggests that actually 1 is the PSA to go for, whereas the majority of the studies reporting so far have been at the PSA cutoff of 3, and there have been studies that have looked at an age-stratified PSA strategy, and in fact this is what's been proposed by the EAU PRAISE-U program. You'll see that patients are divided by age here, and then the PSA level here, and a risk stratification, clinical risk stratification, and if they are found to be at intermediate and high risk, they undergo an MRI scan. So this is the European program. And of course this European program needs optimization and integration, which is what we discussed previously. And the next question one of the questions that we need to ask is, which is the optimal biopsy method, and what does the literature tell us about that? I think this Gothenburg 2 study was actually quite useful, because these men, you'll see 7% had a PSA greater than 3 nanograms per ml. Remember, for prostagram it was 10%, for the Stockholm study it was 12%, and here it's 7%. So the average is coming out to about 1 in 10 men. If you look here, if you took the MRI approach, what you would notice is that the number of men undergoing an MRI should be less, and you'll see. If you took an MRI approach alone, you'll see here that fewer men undergo biopsy. So this shouldn't come as a surprise. But if you took a systematic biopsy and a targeted biopsy in men who were positive, what you'd notice is you'd get a higher proportion of unproductive biopsies, which is, again, what we'd expect. And if you do an MRI targeted biopsy, that will be lower. What you'll notice is that there are fewer men with grade group 1, which is, again, what we'd expect if we leave out the systematic biopsy. But look over here. You'll see that there's a slight reduction in the number of men diagnosed with a clinically significant cancer if you went for an MRI targeted biopsy approach alone. In fact, if you look at the very bottom there on the right-hand side, you'll see that all of these men were grade group 2, no grade group 3 and above. And in fact, the majority of these were microfocal 3+4 cancers, and 6 out of the 10 of these men underwent an active surveillance program. So you will miss some clinically significant cancers, but the clinically significant cancers will be mostly 3+4 microfocal cancers. So those are the cancers that you are likely to miss. The other thing we need to think about is, what is a positive and a negative scan? We've hinted at this in the previous discussion, but let's dig into this a little bit more. Now, in secondary care or early detection settings, we tend to go for a pyrite 3, 4, and 5 because there's a higher pretest probability. We said the pretest probability is between 30 to 50%, so we want a test that's highly sensitive, but you'll get less specificity, obviously. In a screening program, I think we need to think in a different way, because the prevalence is lower. We said the prevalence, remember, was 4% or so, or lower, depending on age, as we said. If you don't do PSA pre-testing, if you do PSA pre-testing, then the prevalence goes up, and in the Stockholm study it went up to 19%. So the prevalences are lower than in early detection settings. Now, if we use a Pyatt's cutoff of 4 and 5, the sensitivity will be less, no doubt about it, but the positive predictive value will be higher, and we want to keep up the positive predictive value, and so that is in fact the preferred threshold. So here is the data that I showed you earlier again, and you'll see that the positive predictive value in the detection setting you'll see is about 10% different if you took a PIRADS cutoff of 3 to 5 versus 4 to 5. So if you do 4 to 5, you get 10% more positive predictive value. And if you take 3, 4, and 5, that drops by about 10%. You can see that over here. So this shows quite interestingly that there is a difference in the PPV depending on the MRI threshold. So what does the literature tell us about this? Well, if we look at the prostagram study again, remember this was in younger men here, 57. Remember what we said before. Very many more positive tests if you do 3, 4, and 5. More unproductive biopsies if you took 3, 4, and 5. Yes? But what you'd find is that you do get a few more cancers diagnosed if you took 3, 4, and 5 compared to a 4, 5 strategy. And you can see that over here. But both strategies, of course, much better than just doing the PSA test. If we look at the BRCA carriers, and again, you'll remember how old those men were. Remember they were 54 years of age. And we expect the prevalence to be low in this age group in the general population. We said less than 0.5%. Look, here it is again, 4%, much higher. You'll see, again, if you did a strategy of 3, 4, and 5, you'd get loads more positive tests. You'd get loads more unproductive biopsies. Equally effective to diagnose clinically significant cancers if you went with the 4, 5 strategy compared to the strategy of 3, 4, and 5. So what that's saying to us is that we really ought to be using 4 and 5 in the screening population before we do a biopsy. Now, of course, what you really should be doing is combining PSA, the age, the MRI findings into a unified strategy. And in fact, some modeling has been done by the prostagram investigators, and these are the data. So if you took the conventional approach of a PSA greater than 3 and a systematic biopsy, you'll see that the biopsy rate will be about 1 in 10, which is what we said, remember. But the cancer detection rate will be 1%. Okay. And this, of course, is level 1 evidence supporting it. Now, any MRI strategy will detect more cancers. So these are the MRI strategies here. And they will all detect more cancers. But if you took these men over here, you'll see, if you take a PSA of greater than 1 and an MRI of 3, 4, and 5, you would end up biopsying a load more patients, so more than 10%. So these are clearly unacceptable, but they'll get you more cancers, which is what we'd expect. If we took these patients here with a PSA of more than 3 and an MRI of 3, 4, and 5, you'd end up biopsying fewer men, and there will be an improvement in the detection of clinically significant cancers from 1 to 1.5%. So it turns out the optimal strategy is a PSA of 1 and a PIRADS score of 4 and 5, which is exactly what we were expecting. Okay, so this seems to be the way we go. Okay, so let's just sit back and try to summarize what we've gained in terms of key messages from these studies. The first thing we need to be cognizant about is that this is single time point evidence. So this is all the data that I've shown you so far is on a one-time use of an MRI. And we really do not have an idea of MRI's effectiveness in multiple rounds of screening. The next is that it does appear that the benefits that we see in the early detection setting does extend to population screening scenarios, but it's strongly dependent on age and the PSA cutoff. It is possible to integrate MRI into screening programs, whether these are risk-stratified or non-risk stratified studies. It is possible to do this. However, the limitations are very much present, and these limitations are too many biopsies, particularly for younger men, particularly if you use 3, 4s, and 5s. There are too many unproductive biopsies, meaning that the PPV is low. there are real issues around reader variability concerns. And again, this seems to be applying to younger men who, of course, are at the lowest disease prevalence. So there is a problem in the younger men for MRI. What about new technologies? Will they help us? We can certainly use risk calculators that are population specific, and these could have a significant impact at reducing the total number of MRI studies that we do, the total number of biopsies that we do, and the total number of low-grade cancers that are detected. We also have some good evidence to show that polygenic risk scores can improve risk stratification also. So polygenic risk scores we know can reduce the number of lifetime biopsies. It does reduce the number of overdiagnoses, but it substantially also reduces the number of MRI scans that are performed. And that enables these polygenic risk scores to be cost effective compared to the conventional PSA screening approach. What about AI? Well, deep learning and AI can certainly accelerate image acquisition. It can certainly improve the analysis, particularly the consistency. But we know that the fidelity of the images are changed. And we know that retraining of AI will be required because of the lower disease prevalence. And we can't just simply plug in what we've developed for secondary care into primary screening without recalibration. That's going to be an important additional lesson. So here are my final thoughts. Population screening is emerging as a new indication for prostate MRI. We know that the harms of PSA screening alone can be ameliorated by introducing MRI into this process. Clearly, there's a need to optimize the MRI for screening, to refine the protocol, to establish accuracy levels. We need to be thinking about reliability interpretation criteria. The optimal utilization of MRI will be in a multi-step screening program. So it has to be quality assured, it has to be cost effective, and it has to be in a way that ensures community access to the greater number of patients who can benefit from the scarce resource of an MRI. I'd like to encourage you to read these two articles, and the first article basically covers what we've covered today, but in written form. The second article, bottom left, covers how we optimize imaging and integrate it into a quality assured program, and the corresponding YouTube videos are available on your right hand side to enjoy and look at again that deal with these two subjects. I hope you found some of these remarks useful. Leave me some comments. Thank you very much.